Welcome, everyone, to this session, Health Outcomes Research, What's in a Choice? I'm Susana Perez from RTI Health Solutions in Barcelona.
And I am Danica Marinets-Davic from USFDA.
And it's my pleasure to introduce the first speaker, Kathy Suda from the Center of Health Equity Research and Promotion and the Veterans Administration in Pittsburgh healthcare system, who will be talking about association between angiotensin receptor blocker, drug recalls, and adverse clinical outcomes in patients with heart failure.
Thank you for that introduction. I'd like to recognize my co-authors, and I would like to mention that I'm presenting on behalf of Dr. Josh Devine, who led this analysis but was not able to travel to Halifax. This research was funded by an R01 awarded by AHRQ, as well as informed by 2 grants awarded by the Veterans Health Administration and the Canadian Institutes for Health Research. 2 of the co-authors do have conflicts of interest, and importantly, the opinions expressed today are those of my own and do not represent those of the US government. Angiotensin receptor blockers, or ARBs, are first-line treatments for hypertension, heart failure, and renal disease. But in July of 2018, the US Food and Drug Administration announced a voluntary recall of most generic valsartan products available in the US, following the detection of carcinogenic impurities. This impacted the global supply chain, and there were multiple other recalls in many other countries worldwide. The figure in this slide is from our previous work, which showed an international impact of this recall on the available valsartan supply worldwide. However, the impact of the valsartan recall on patient outcomes in the United States remains unknown, particularly among sicker patients with heart failure who are particularly prone to decompensation when medication changes occur. So our objective was to determine if patients with heart failure receiving valsartan at the time of the 2018 FDA recall and the subsequent drug shortage that occurred had a greater likelihood of poor patient outcomes than individuals using similar drugs that were not affected by the recall and shortage. We used a claims data set of commercial insurance and Medicare Advantage plans available from Optum. Within this data set, we identified adults with heart failure using a validated algorithm typically used by AHRQ who had a diagnosis of heart failure prior to the FDA recall date of July 13, 2018. Within this cohort, we then identified active users of ARBs and ACE inhibitors. We defined active users as those with an 80% or greater medication possession ratio for a year, and in addition, they had a day's supply that overlapped the index date. We then excluded patients receiving losartan and irbesartan because these 2 medications experienced similar recalls within our study period, our follow-up period. So we had a 1-year pre-index baseline period where we identified the cohort as well as defined our baseline covariates. After our index date of July 13th of 2018, we then looked at a 6-month time period to assess our study outcomes. Our primary outcomes was a composite of all-cause hospitalization, emergency department, and urgent care visits. We also looked at a measure of cardiac events, which included hospitalizations for myocardial infarction and hospitalizations, ED, or urgent care visits for stroke, TIA, heart failure exacerbation, or hypertension as the principal diagnosis. Our secondary study outcomes were all-cause mortality and the individual components of the cardiac event outcome. Because the active use of our treatments are likely to vary by important patient characteristics, we employed inverse probability treatment weighting using propensity scores derived from logistic regression. And we assessed the balance in covariates using standardized mean differences. Our primary outcomes and our clinical outcomes, meaning the cardiac event outcomes, were assessed using Cox regression models with inverse probability weighting by the propensity score. And for mortality, we did not have the exact date of death for these patients due to data limitations. So we used weighted logistic regression versus the time to event approach. Patients who were lost to follow-up, disenrolled, or experienced another event were right-censored. So we identified over 500,000 individuals with heart failure who had insurance for at least a year during the pre-index baseline period. Again, looking at commercial insurance and Medicare Advantage plans. After exclusions, there were 73,000 patients receiving medications that are generally considered to be clinically equivalent to valsartan, which were the non-recalled ARBs and the ACE inhibitors. And 15% of the cohort, or 13,000 individuals, were actively using valsartan with drugs with supply that overlapped the index date. So not surprisingly, our cohort was an older population with about a mean age of 75 years in each group. 51% were male and 66% were white. There were imbalance between several important variables within our cohort, including gender, race, geographic region, and some medical comorbidities. But these were largely within balance after applying inverse probability weighting, which is shown in the right-hand side of this table. So over 1/3 of each group had some kind of healthcare utilization within 6 months following the recall date, either hospitalization, an ED, or an urgent care visit. However, there were no differences between groups, which is shown in the first row of this figure. We also did not find any differences in our cardiac event measure, which is shown in the last row of this figure. We did find a small decrease in hospitalizations and emergency department visits in the valsartan group when compared to those receiving non-recalled ARBs and ACE inhibitors within 6 months following the recall date. And we did see an increase in urgent care visits in the valsartan group when compared to the ARB ACE inhibitor group. For our clinical outcomes, we also did not find any differences for heart failure, myocardial infarction, or for the overall hypertension composite, which looked at hospitalizations, urgent care, or ED visits. We did identify an increase in hospitalizations where hypertension was the principal diagnosis. But overall, these events were relatively rare, only 0.2% in the valsartan group and 0.1% in the ACE-I and ARB group. Again, we did not have the exact date of death, so we were unable to do time to event. So using logistic regression, we found a decrease in decreased odds of mortality in the valsartan group when compared to ACE-I and ARB patients receiving ACE-Is and ARBs within 6 months following the recall date. There are limitations to this analysis. This is an observational study design using administrative claims data set. We also excluded important ARBs such as losartan and irbesartan, which did experience similar recalls toward the end of our 6-month follow-up period. The data vendor applies an algorithm to determine race and ethnicity of these patients, and it's not self-identified. We also used a cohort that was largely adherent to their medications because we wanted to attribute events to the FDA recall. However, adherent patients may experience different health behaviors, which may not be generalizable to patients who are less adherent with their medications. So overall, we did not find that the valsartan recall did not affect the short-term outcomes of patients in the United States with heart failure. This is likely due to multiple causes. The Food and Drug Administration and several health systems encourage patients to continue taking their medications until a suitable alternative could be provided to the patient. In addition, this is an example of a recall and a shortage of a medication that has multiple suitable alternatives available in the US market. And the ability to prescribe or provide a patient an alternate medication likely prevented patient harm. However, 15% of our cohort were active users of valsartan. Thus, this potentially disrupted the medication regimens of in 6 patients with heart failure in the United States. And thinking of this from a population level, the number of patients requiring treatment switches is staggering. However, as drug shortages continue to plague countries worldwide, we need more data on the impact of shortages. We know that we need to know how this impacts patients with certain conditions. We need to quantify the problem. We also need to better understand the strain both on patients and the healthcare system to manage treatment switches and overall recalls and shortages in general. So I'd like to acknowledge my collaborators on this work. I already mentioned Dr. Joshua Devine, but Dr. Mina Tadros, who's co-leading this body of work with me, Dr. Emma Hernandez, Nandita Mukhopadhyay, Dr. Scott Rothenberger, soon to be Dr. Catherine Calloway Kim, who's presenting our overall shortage work on Sunday afternoon in the 1:30 session, and Dr. Walid Jalad. Thank you for your attention, and I look forward to your questions.
Here. So are there any questions from the audience for our presenter? Don't be shy. I know it's short after lunch, but any thoughts, any questions? Perhaps I could just ask a question actually coming from the FDA. What are your thoughts of what FDA might be doing more in terms of promoting this type of research or doing something in conjunction with a particular recall? Any thoughts from your perspective?
As you know, the FDA is restrained by what they can and cannot do. So manufacturers, while they are required to report any potential impact on drug supply, this is not actually, there's no retribution to the manufacturers if there's nothing. In addition, trying to increase the quality of the product that are produced, especially for generic products, I think is really important in this case. Mm-hmm. And also to provide really pointed, direct, simple instructions to patients on what to do. Mm-hmm. And then providing latitude for how we can provide patients with additional supply. I think it's very complex, especially in outpatient healthcare settings, to provide patients, tell them that there's no medication available. That usually occurs from the pharmacist in a community pharmacy. The actual prescriber has no idea that this is a problem, that the medication is not available. And then there's just such a disjointed system. Mm-hmm. Versus in acute care or long-term care, those patients are there, right? They're captive audiences. And typically they don't even know that this is happening, that there is a shortage. But in outpatients in the community, they're acutely aware that we're not giving them their medication. And in this case, that it was a carcinogen causing the impurity. So I think there's a lot of work we need to do just for our patients to understand that there's drug shortages and why those are occurring.
Thank you. All right. Yeah. Oh, I'm sorry. I didn't realize you had a question. Hello? Come this way.
The study showed a 14% increase in all-cause urgent care visits. And I was wondering whether you had a chance to look a little bit into the cause of those visits, and for those of us not in the United States, whether this could reflect patients going to get their medicines represcribed, or thank you.
Yes, yeah.
It looks like the only way.
So the question was regarding use of urgent care. Yeah, it's possible that some of this could be due to getting new medication just from urgent care. The emergency departments in urgent care in the United States frequently are sometimes used as a safety net when patients cannot see their primary provider. However, we've not looked into the exact reason. The urgent care cardiac event was due to a principal diagnosis, so it had to be the primary diagnosis of the encounter. We are actually doing additional work in this space, so we are hoping to find more information. Thank you.
Thank you. Now it's my great pleasure to introduce our next speaker, who is Lawrence Bloem, who is the professor at the Utrecht University in Netherlands. And the topic that he will be presenting is regulatory and health technology assessment of cell and gene therapies in Europe, convergence or divergence. So let me just try to go back. One more. It's supposed to be a shortcut, but it's really not a shortcut. Why they?
Yeah, thank you for the introduction. Let's see. Oh, yeah, it's working. So I have nothing to disclose. I wanted to talk to you about cell and gene therapies or advanced therapy medicinal products. In Europe, we call them ATMPs, and it's good to define them well. I think the definition in Europe is a combination of gene therapies, which could include cell-based gene therapies, which are ex vivo cells, cell therapies, but then excluding hematopoietic progenitor cells, which are also regulated by the FDA, and tissue engineered products. So that's the definition I'm actually using here. And typically these medicines are really important, or these products, because they can actually target diseases with a high unmet medical need, where potentially there was no treatment yet, nothing available, and potentially it can even provide a cure for these diseases. So if you just quickly look how many products have been authorized so far, until 2022, there's 24 products in the European Union, 19 in the US, if I follow the exact same definition as in Europe, 17 in Japan, and there's fewer than in many other countries in the world. Then, if you look at Europe, there's quite a big issue of these therapies actually reaching the patient. And since 2009, 7 of these 24 patients have been withdrawn from the market again. And one potential reason that has been put forward is the health technology assessment, or the assessment for reimbursement. This is quite a big issue, and I think one of the most important well-known cases are the therapies of Bluebird Bio. They had 2 gene therapies, and they actually withdrew completely from the European market because they did not get their products reimbursed, and they're still on the US market. And as far as I know, most products, or actually all products that have been authorized by the FDA, are still on the US market, but Europe has this share of almost 1/3 of products that have been withdrawn from the European market. So what did we do? We wanted to look into this, and we wanted to see whether there were potential differences in evidence base between the European Medicines Agency from the regulatory assessment side and the reimbursement assessment side, the HTA, for decision-making about ATMPs in Europe. And we compared the European Medicines Agency with 4 HTAs in Europe, being the Dutch, the French, the German, and the English/Welsh HTA. So we actually compared benefit risk assessment with relative effectiveness assessment. So we did not take into account the cost considerations, because of course the EMA also doesn't do that. We looked at the pivotal studies, the supportive studies that were actually used to support the decision-making, the main efficacy endpoints that were considered, so not necessarily the primary endpoints, but the main efficacy endpoints, and also looked at the key remaining uncertainties. And these are the therapies that were in the end, or were actually assessed by any HTA agencies in our cohort. So it's of those 24, there were 18 products have been assessed by an HTA agency until December 2022. They had 19 indications, so we included 19 product indication combinations. And what you can see here, what I think is good to note, is that as of 2018, all therapies have been assessed by all of those 4 HTAs, while before they weren't. And also as of 28, they were all gene therapies. Looking at the evidence basis, we can see that the pivotal studies were uncontrolled for 12 out of the 19 studies, and especially also for all gene therapies as of 2018. And typically these were the same pivotal studies that were used for the EMA, but also for the HTA decision-making, with also about the same similar patient follow-up. So really the same type of data. There's a few exceptions to that, being Glybera, Kymriah, and Zolgensma, where there were 2 extra uncontrolled interventional trials for some HTA agencies. But in general, it was really similar, and also the same main endpoints were used for decision-making, except for some oncology medicines where the HTAs focused on survival endpoints, while the EMA more focused on objective response rate, which was actually the primary endpoint of the uncontrolled studies. But if we then dive into the supportive studies, you see quite some differences. And we really saw that, like, firstly, in the number of supportive studies. So there were quite a differences between agencies. And for example, Kymriah, 2 supportive studies from the EMA side, also 2 for GBA, which is the German agency, and for the Dutch, but 6 for the French, for instance. And we saw more cases like those, so quite a bit of distribution in number of supportive studies. And then if you look a bit further, we also saw a big difference in the role that these studies had. So the EMA definitely had more emphasis on confirming the effect of the intervention. So not only looking at the pivotal trial, but really also looking at other trials, often interventional studies, to support the knowledge on the effects of the treatment. While HTAs more looked at contextualizing those results. So really looking at what other treatments are there and how does it compare to their effects. And there was also a larger share of observational studies for the HTAs. And then we saw also quite a big differences between the HTAs. So even between all of them, there were different types of studies and different roles also of the studies in their decision-making. And then another step that we did is actually have a look at how many or which uncertainties were found by the European Medicines Agency and by the HTAs. And this is not really readable, and I'm just going to highlight a few points here. We did this along the lines of uncertainty categorization as done by the European Medicines Agency, and we added 2 categories to it. These were the key categories of uncertainties that remained after the decision-making. I just want to highlight a few. I think here on the left, this category is named the quality of the evidence, especially of the pivotal evidence. And we really saw that there was a really big issue with a lack of a comparative pivotal study. And it was important for the EMA. The EMA, of course, made their decision being positive, because that's why we included it and looked at HTA at reimbursement decision-making. But we saw mainly for the German and for the Dutch agency that they had really big issues with this. So you can see the very high rates, 93% of the German and 100% of the Dutch agency had key uncertainties about the lack of comparative studies. Then the second one is precision of the effect size with regard to the efficacy endpoint. And there you can actually see that everyone had an issue with this. All agencies had an issue with this. And that really regarded the lack of power and the attributability of the effects to the products. Also, of course, as a result of the single-arm design or uncontrolled design. My apologies. Coming to the 4th red box, or maybe first to the 4th. What is really interesting there, I think it's good to see that a lot of HTA agencies were happy that there was some comparator, some external control, often based on observational studies, but they still had a big issue with that comparator and the choice of the specific comparator. So they still wanted actually to have a different one or like different data. So it was still a really big issue. And the EMA never came with that uncertainty because they often actually relied on the single-arm trial themselves, accepted the fact that there was some external control, but mainly focused on the single-arm trial. And then what I found striking myself is the middle one, the natural history / course of disease. I expected many more uncertainties on that, and actually weren't that many. So the key uncertainties were not necessarily focused on, do we actually understand the disease to contextualize the uncontrolled trial studies? And I actually expected a lot more there. Another thing that I found interesting is that there was this uncertainty, the clinical meaningfulness of the endpoint, of the efficacy endpoint. And there, EMA had much more uncertainty on it than the HTAs. While the EMA, of course, already had made a positive decision, and I expected actually the HTAs to have a much higher uncertainty on the clinical meaningfulness. So it's definitely something to dive into a bit further and to really try to understand it. But apparently they're much more on the side of the precision of the effect, estimating it, really coming to the relative effectiveness, and of course also to the cost effectiveness point, not necessarily on the clinical meaningfulness. And if we then look how this actually impacts their decision making, then you see here 4 plot, 4 boxes, first for the German agency, then for the French, the English, and for the Dutch. And on the left-hand side, you see the end decision based on the data that I just showed you. So really only on the effectiveness data. And for the German one, you see a lot of negativity. It was really based on the quality of the evidence. The lack of the comparative study design was mainly the issue for Germany. It also comes back to the point that I made for Bluebird Bio. Then for the French, you also see some negativity. For the English, almost half of it. And for the Dutch, it was actually not that big of an issue. But in the end, it translates to the plots next to it. It translates to a more positive decision often. And in green, it's actually a full positive decision. In red, it's negative decision. And then in the grayish, it's a decision with a restriction. So it's often a restriction based on price or on the clinical population. So we actually see that there's the uncertainties are often translated to a restriction in price or in the clinical population of these therapies. So in the end, they can make it to the market, but especially NICE, the English agency, really makes a lot of price restrictions discussions with these agencies to make sure that they're actually available on the market. And then I think it's good to note that these are recommendations by these agencies, and that they're not always their main authoritative body that make the end decision for a country. So it does not fully reflect patient access. So coming to the end, I think what's good to note that generally they had the same pivotal main studies as evidence-based, but we do see some very big differences in supportive studies, also including their role in the decision-making. And what is difficult here to grasp from the reports is whether the company had a specific submission strategy of this evidence, and also whether they discussed this with the HTA agency. So that would be really good to understand better. There's a lack of comparative studies that really seems to translate into HTA uncertainties and also impact patient access. And we're currently zooming in on this 2018 to current cohort to see on the product level for each HTA agency. So what is the real role that's playing or that's really impacting the patient access here? Is it the evidence, or is it also HTA practice for a specific country? Happy to take any questions, and I'd like to acknowledge these people.
Thank you very much. We have time for one or two questions if they're fast. Please identify yourself.
Sure. Wei Zhou from Eli Lilly. Very nice presentation. Congratulations. My question is regarding, we know there's a difference between HTA and EMS. What are the unique aspects here when you talk about gene therapy versus some other, like expensive cancer therapies with a huge unmet medical need? Thank you.
Were you going to use it too?
So your question is, what other than unmet medical need?
Compare the gene therapy with other kind of therapeutic area. What are the unique difference regarding the discrepancy or difference between HTA and EMA?
I think one of the main issues here is also especially you see in the last gene therapies, they're almost all gene therapies. They're like one-off treatments, and HTAs really have a big issue with trusting that a one-off treatment indeed delivers the effect that we expect from it, and on the total time horizon, being it 10, 20, or maybe even more years, and then being sure that they pay for the value of that one-off treatment. And I think that's the biggest issue. So you need to invest, you need to trust the product.
Thank you.
Yeah.
Any other question? I had one. We hear about the collaboration between regulatory agencies, EMA, and the national agencies, obviously, to make the regulatory decision, also internationally with the Food and Drug Administration, Health Canada, etc. Is there a similar collaboration system with the health technology assessment groups?
Yeah, I think that's an excellent question. And last year, there was a European regulation passed to have more collaboration between the health technology assessments in Europe, or agencies. And they are trying to collaborate on several levels, but also I don't think the regulation is now that strict that we are actually enforcing the collaboration. So they still have the room to get make a national decision in the end, but there's definitely work there. Yeah.
Thank you very much.
Sorry,
yeah. And it's a pleasure to introduce our next speaker, Sam Su from the Department of Pharmaceutical Care and Health Systems College of Pharmacy at the University of Minnesota.
Thanks for the kindly introduction. My name is Sam Xu. I'm a PhD student from College of Pharmacy in University of Minnesota. It's my great pleasure to present my research work at the ECPI here. My presentation title is Using a Target Trial Framework to Compare the Effect of High versus Low Opioid Dosing Strategies at Post-Surgical Discharge on New Developed Opioid Use Disorder. I have nothing to disclose. So just imagine that you were a surgeon, you have a patient, he or she undergone the surgery, and now you want to discharge her or him from hospital. And now you wonder how much opioid you should prescribe if patient need that. Some issues and background for the opioid prescribing in this field is we all know that inappropriate opioid prescribing remain an issue in the US, particularly there are over prescribing in post-surgical setting in the US. And even though for the same or similar procedures, there is a wide variation of opioid prescribing for the dosing. And there is no consensus of guideline on initial post-surgical discharge dosage, how much should be prescribed. And there's no randomized clinical trial to answer these research questions. So this really motivated us to use a target trial emulation to answer these questions. Our research question is, would surgical patient discharged with high total MME associated with higher risk of new opioid use disorder in 2 years than patient discharged with low total MME? And we are using a target trial approach using real-world data to emulate randomized clinical trials to support clinical decision. And if you're like me, trying to learn how to use target trial emulation, those are good starting points. There are some tutorial and review articles, how you emulate target trials. And there are also some examples that how they use target trial emulation in different settings, like dialysis, diabetes medication choice, and when do you start or stop ARS or ARB inhibitors, and also the group for the policy evaluations. And go back to our research questions. So right now there's no target trial emulations in opioid prescribing in post-surgical settings. So this is our target trial protocols, like 2 steps. First is you imagine what is the protocol, what would be looks like if you are conducting a randomized clinical trials. And then you use your existing data to emulate that research questions. And then here's a brief version of our protocol component. So basically, this is the same if we have another column as a target trials, like your eligibilities, treatment strategies, high versus low, and how do you assign your treatment strategies. And because we don't have the randomizations, so we are using inverse probability treatment weighting to mimic randomizations. And then we follow up to 2 years for our outcomes, which is a new developed opioid disorder. And then our causal contrast of interest is intention to treat, because we are using prescribing information from EHR data. And our analysis plan is to evaluate the 2-year risk of new OUD based on high versus low MME at post-surgical discharge. More about methodology. This is for your information, like the PICO framework. Inclusion criteria, we restrict our population to adults patient and first surgery with opioid prescribed on discharge. And it is 1 outpatient visit with primary care provider within 2 years prior to the index surgeries. And then there are other exclusion criteria, such as if there are prior surgery or prior opioid use, or existing opioid disorder before the index day or as the time 0 of the discharge. Some covariates, age, sex, gender, and surgical factors, and pain-related medication use and comorbidities. statistic analysis, we are estimating the relative risk by standardized log binomial regression model. And to avoid inflection of using the propensity score with the inverse probability treatment weighting, we use a stabilized ways to balance that. And we also conduct a couple of sensitivity analysis by different threshold of high versus low MME, and also for the outcome, different years, like 1 year, 2 year, and 3 years OUD. Our data source is electronic health records from mHealth Fairviews, and that is in Minnesota. And this is more information about our data source. If you are interested, you can look into from the QR code. A little bit more information, after we receive the database, and then we extract those information from different relation tables, and then we created hundreds of variables for our research question and based on our protocols, and then we analyzed the data. This is the flow chart of our study population. At first, we identified 179,000 patients, and after applying those inclusion and exclusion criteria, after all, we have about like pretty much the same population, 50-50 in the high versus low MME group. And this is the covariance balance based on our stabilizing inverse probability treatment weighting. So you can see from the left, it's pretty not balanced, but after applying the propensity score inverse probability treatment weighting, the two groups, high versus low MME group, are pretty balanced based on the covariates. This is our result. For the primary outcome is 2 years OUD, and you can see that for the relative risk is higher, about 73% higher in high MME group compared to low MME group. We also examine other secondary outcomes for most of those: 90 days ED visit, 90-day all-cause mortality, or persistent opioid use at either first to 90 days or 91 days to 180 days after discharge. They are significant higher. For others, 1 year all-cause mortality, and another secondary outcome we are interested is the kidney function, kidney dysfunction. So those are not significant. For the sensitivity analysis, we choose different thresholds to determine high versus low. And as you can see that this is to visualize the figures. You can see the relative risk increase as the threshold getting higher from like 200 or 300 or 450. So it seems that there's a dose response between high versus low, like threshold to the 2 years opioid use disorder. Another perspective of the sensitivity analysis is we're trying to see different outcomes for the same 200 MME high versus low. And you can see at the different years, we all see that high MME group has higher risk of opioid use disorder. So summary, compared to low total MME group, the high total MME group had a significant higher risk of new OUD at 2 years. They are also associated with other opioid-related adverse events such as ED visit, persistent opioid use, and all-cause mortality in short term at 90 days. But we didn't see high MME group is associated with decline of eGFR greater than 40%. So the take-home message is initial opioid dose does matter, less is more, and target trial framework is feasible to support clinical decision-making in opioid dosing strategy at post-surgical discharge. This is my reference. I would like to acknowledge those people, especially my professor, Wendy St. Peters, and all other co-authors and colleagues. Thank you.
Yes, Julie, please come to the mic and introduce yourself. Sorry.
Jody Siegel, Baltimore. Thank you for the nice talk. Did you try looking at different cutoffs besides 200 and less than 200? Maybe there's a threshold that's okay.
Yeah, so back to our sensitivity analysis, because 200, yeah, so we did look at different threshold. Yeah.
Hi, Sophie Botts. Thank you for your talk. Maybe I missed it, but I was wondering how you identified people with opioid use disorder in your database.
Sure. So I'll refer back to these slides. So in the EHR data, we have diagnosis table. So we use diagnosis code ICD-9 and ICD-10 to identify opioid use disorder, and that those code lists was based on the published articles in JAMA. Yep.
Thanks.
Thank you.
Thank you.
Do you have any question? Okay, so then we have to come up with more questions. It
I
looks
actually
like
had the question before I found
Okay.
out we have 4 minutes more. What was it? Oh gosh, I'm having a blank here. Maybe I missed it, but when did you look into the types of surgery? I mean, clearly the answer is less is better. But did you look into to which extent the type, an extension of the surgical intervention would drive the initial dose of opioids?
Yeah, so thank you for that question. That's a good question because we do look into different procedure type and like specific like cardiovascular, orthopedics. What we do is we adjust those individual surgical types. And we also did other analysis I didn't show here. Like we are wondering whether the association we observe will be modified by major versus minor. And it turns out that the interaction term or the RERI is not significant. So that support us to present our result as a pool analysis. But that is an interesting question to separate like major surgery versus minor surgeries to see the association. But we did do that, yeah. Are they opioid naive? Yes, so they are opioid naive cohorts. Yep.
How did you NAB Descouped University of North Carolina, Chapel Hill? How did you calculate MME? Was it MME per day? Was it the initial script, and how did you account for the overlapping scripts?
Yeah, that's a really good question because in post-surgical setting, MME is different from chronic use. So if you refer to the CDC guidelines, like either 2016 or the most updated guidelines, it focuses on chronic use, like average MME. But what we use here is a total MME. That is the discharge prescription from all source. So we basically still apply those conversion factors, but we calculate as a total MME, not average MME.
Got it. Thank you.
Yep.
You had a really clean starting point with the discharge, but I'm wondering if there's any if the decision of prescribing upon discharge is somewhat tied to the decision to discharge or extend the hospital stay, and if you accounted for it.
Yeah, so that's a good question because in our data set, there's no column to indicate what is discharge prescriptions. So they go back to your decisions. So we use a 2 days window that is outpatient active prescriptions based on the discharge date. So it ensures that all our exposures is a prescription at discharge. Yep.
Just one more quick question. Are you planning to continue this work or do a little bit more in the same realm?
Yeah, so one of the extension work is we're trying to use natural language processing to look into the unstructured nodes because we encounter some missing data, for example, like pain score. Not all patients, they have pain score. So we want to know for those have pain score measurement versus those who don't have pain score measurements, what are information from their like discharge summary? And that is one of the next step for us. Thank you.
Thank you. Thank you very much.
Thank you.
So now I'm actually introducing now one super presenter for today. She's going to give 2 talks. Her name is Julie Laufenberger from Brigham and Women's. First talk is going to focus on novel uses of adaptive designs to guide provider engagement in electronic health records, a pragmatic adaptive database randomized trial. And the second talk will be focusing on personalizing communication to improve medication adherence using reinforcement learning, a pragmatic randomized trial. I think Dr. Califf would be really happy to hear, based on some of his suggestions from this morning, where the work should go. So let me just try to get... Oh. So now it's 2:15, right? Yeah. Okay. All right. Maybe slide show. Go ahead.
Cool. All right.
For some reason, it's not. I don't know why it's not acting on my touch. One more time.
Okay, I'll figure it out there.
Oh, it is already.
Yeah,
No.
that's fine. Okay. Thank you for your attention. And I'm as you said, I'm Julie Laufenberger, and I'm here to talk about a pragmatic adaptive trial that actually came up in the one of the symposium last year. We were talking about how to think about deprescribing from electronic databases. So I'm excited to actually show the results of what our team has been working on over the last couple of years. And so first of all, I have no disclosures to report. Oh, these slides are not advancing on here, so this will be kind of weird. Okay. But basically the motivation behind this is that deprescribing in itself is a challenge. And you know, even this idea of deprescribing in and of itself as a terminology has been kind of increasing in interest over the last few years. And we decided really to focus here on medications like benzodiazepines and sedative hypnotics, because many individuals who are actually using them are using them chronically for insomnia and anxiety. And there's a lot of reasons why there's some overuse problems with these medications in older adults. And moreover, there's challenges in having patients come off of these medications, even when there's an agreement in place to help them deprescribe, because there's issues with withdrawal and other considerations. And in a lot of the focus grouping and other work that we had done to design this project, we found that particularly primary care providers felt like they were lacking a lot of the tools or opportunities really at the point of care for them to really initiate deprescribing conversations in this population. And so there was an opportunity for us to think about, you know, a constrained way of thinking about how to build out these tools for providers. So we focused on electronic health record-based approaches here in the US. And, you know, one reason we focused on them was that was kind of a key first starting point for us. But there had been some level of evidence in the literature to suggest that well-designed EHR-based tools could help with prescribing decisions. But a lot of the ones in the past have had some limitations. Namely, the biggest one we hear about in the literature is alert fatigue. Any practicing provider will tell you that they get lots of these alerts. And there's clinical inertia associated with these medications in particular. And others have identified that some of the biggest issues surrounding these types of electronic health record-based tools is perhaps when they fire in workflow, what the information is relating to, maybe not including the best functionality. And so our team wanted to take a step back and think about whether we had an opportunity here to test different behavioral science techniques head to head to see which ones potentially for this problem made sense. But because there were really many different ways we could think about designing electronic health record-based tools, we sought to come up with a design in tandem with our biostatisticians that might allow us to test multiple ones at the same time, which is what led us to thinking about an adaptive trial design. And so this is the results of a trial that we've been working on the last few years. And the overall trial objective is to evaluate the effectiveness of different electronic health record-based tools on deprescribing medications like benzodiazepines and sedative hypnotics for insomnia. And we used a 16-arm design actually to do this. And it was a database randomized trial in that we randomized primary care providers in a large integrated health system in Eastern Massachusetts across 26 different practices. Patients and providers were both identified through electronic health record data, so there was no informed consent that was necessary for them to be included in the study. And the intervention itself was electronic health record interventions that were delivered for PCPs for patients who were chronically using these medications defined by EHR data. And basically we went about this is one example of really some basic information about what one of the tools that did it stop moving? I'm so sorry. This is broken, I think. I wish you had told me. Sorry, I'm like talking. Can we move? I closed it. I think it's frozen. Try to close all of them. Thank you for stopping me. Cool, now it's working. Sorry about that. Okay, well, you didn't need to see the words on this slide. I explained it anyway. So here we are with the what the decision support itself looked like for one of the arms in the study. And so I'll show you kind of, there were different pieces that we modified for each one. They were mostly all alerts in nature, but we essentially changed the content of what was in there and included different behavioral science principles. And so the way we ended up doing this as a 16-arm trial was that for each of these alerts, they were categorized as whether they included different intervention components that we were testing. So ultimately, some of the arms included different types of timing that we were testing. Some of the arms had a follow-up booster. Some of the arms had different types of outreach that was happening. Some of them had different language. And so by doing and testing things across the different arms, we could actually consolidate sort of our power and what we were able to analyze because we were testing things across different arms. And we did this in an adaptive way, again, to try to see if we could test multiple things and increase our power. And so what we ended up doing is we randomized individuals to 16 different arms. We put the balance of providers in the usual care arm that we were testing, so that in the second phase, we could identify the top 5 performing arms and allocate more of the usual care providers who never saw anything to some of those top performing arms. And ultimately, we did this over 2 stages where we had about 8 months to 9 months of evaluation for both stages. And our primary outcome was from electronic health record data among those who were eligible and in need of deprescribing. And we spent a long time thinking about what deprescribing meant in this context and how we could measure it. But ultimately, we decided on discontinuation of one of the medications, an absence of an order over follow-up, and ordering a taper that we could measure in the EHR data for one of these medications in the stage in which we were evaluating them. So our analytic plan ultimately was a generalized linear mixed model, where we incorporated those different behavioral science intervention factors in a large model, essentially, in their association with the primary outcome of deprescribing. And we pooled the data across both stages, ultimately for our primary analysis. We, of course, adjusted for the clustering and the block randomized design that we had, included other fixed effects we thought might be relevant, and patients could ultimately only be included once. And so that's really how we set up the design ultimately. So what did we find? Well, we found in our primary analysis, I should say, was really testing these factors. It was not arms. And so this has been very confusing for clinicaltrials.gov as we've been publishing our results, I'll add. But ultimately, we were comparing these factors. And so we prepared and present our results on the level of the factors that we evaluated. And so our primary outcome is really what we're focusing on. And we had about 3,000 patients ultimately included in our sample. And what's kind of notable is that where the biggest difference and the driver of deprescribing was really not having an order during follow-up. And that was really the big balance of our composite outcome. And so when we did our unadjusted results, in our adjusted results, in terms of this composite primary outcome that we were looking at, really only one of the factors kind of started to show that there was potentially a difference compared with usual care in terms of having that factor or not. And so the biggest thing was really actually timing. So whether the alert or the decision support appeared during a situation where the providers were actually opening encounter and about to see a patient rather than when they were prescribing or refilling a medication. Believe it or not, like that was one of the things that was really most interesting to us. And we saw a non-significant, but 20% increase in deprescribing for that type of timing. Other types of adjustments didn't really change the results. And really this was driven by just not having an order written. Somehow, somewhere along the way, there was just no order written for that patient, even though they appeared over follow-up. And so the other thing then, when we were starting to think about this timing issue, which appeared interesting to us, was, well, what happens if we look within the arms where the medication was being written at this open encounter timing, when the providers were actually opening an encounter about to see a patient rather than refilling a medication. And so one of the most interesting things to us here was that this idea of pre-commitment, which really was a two-stage type of decision support that we had designed, where the first ask in the first visit was solely to share a handout. It was not to ask providers to actually do any deprescribing at that time. It was actually just to get them to have a conversation. This one was really effective when we looked at providers who were actually getting this at the time of open encounter. So all this to say, we completed an adaptive trial during COVID, which to me is still something I'm incredibly proud of. Basically, we think that EHR tools based on this and other literature have some benefit in assisting providers with deprescribing. And for us and for what our results showed, the most promising action in time if we're thinking about this problem was when opening an encounter rather than ordering or refilling a medication when it might be too late for providers to have that information and be useful to them. And within there, the most promising behavioral principle was this idea of pre-commitment, which really could be explained by a stronger engagement that we brought in with the patient. And so the other thing is, we think there's some lessons here. We're thinking about how to do other database randomized trials and leveraging how we might be able to do more adaptation in our designs. So with that, I absolutely want to thank the team and the other individuals who have worked on this project across different health centers. And I'd be grateful for any questions that you have. Thank you very much.
Thank you. Any questions from the floor? We have time maybe for one or two. Okay. I had one. I think the finding about opening encounters kind of makes sense from a clinical point of view, because that gives the clinician an opportunity to say, well, in addition to whatever they're coming from, I'm going to ask them about how well they sleep or whatever. Did you have a chance to check back with the healthcare practitioners in the system, whether that was why this may be working this way?
Yeah, it's a great question. So we ended up doing a lot of post hoc qualitative interviews with PCPs too, which sort of informed they were all like, oh yeah, of course, talking with the patient, we need more handouts. Like this makes sense. They were not at all surprised by the results that we had. And in designing and in these post hoc interviews, they all kind of called out timing as really being something of relevance. So it felt like we had kind of the justification to back up the rationale that we saw from the data.
Thanks. Jody Siegel, Baltimore. Just two brief questions. The fact that they were at the beginning at the opening of the encounter, does that imply that somebody else was teeing up the order?
So they basically were agnostic to whether they ordered an order. It was we were identifying patients based on the presence of them having had an order in the past that was still active. So these alerts, decision support popped up at the time that the provider was opening the encounter. So it didn't matter if actually they were teeing up or writing a medication. It was really just about that encounter itself. So if someone else wrote for the medication, which we know happens, maybe less for these medications that are controlled, they wouldn't have gotten the alert related to that.
Okay, thank you. And then you didn't have, it wasn't active deprescribing as your outcome, right?
Yeah, so the primary outcome was actually a mix of passive and active deprescribing, which is partly why I think there was some kind of interesting mixed results, because for 2 of the 3 components that went into it, they had to actively deprescribe or actively discontinue or actively taper. But for many of the patients, more than we expected really when we were powering this, a lot of them just passively were not re-prescribed anything, even though they had come back for a visit and had been chronically using the medication.
Mhm. Thanks.
Yeah, thank you.
Hi, Marie Lyles-Burden from Takeda. Thank you so much for this presentation. Just to almost extrapolate a little bit further more into the industry space, where some of us are required to do risk minimization activities to communicate risk, either through patient brochures, patient alert cards, things of that nature. Could you talk a little bit about how something like this might, thinking about other agencies that are starting to think about integrating those alerts or conversations with HCPs to be able to provide that patient alert card, to have that conversation. Could you speak a little bit about if there was any conversations about how do you, I guess, appropriately time that alert in that conversation? Thank you.
Yeah, no, I think it's a great question. We were really focused on the provider. I think there's a lot more that I think what you're getting at is there's a lot more that could be done for other actors. This was really just kind of what we were funded under as our foray into thinking about providers. But I think there's a lot more that could go into risk communication.
I'm afraid we run out of time, but maybe there's some time after the second presentation.
Sure. Or I'm happy to stick around at the end. Okay, so you're back listening to me. Great. So I'm Julie Laufenberger, Brigham Women's Hospital. And so this is actually a different pragmatic trial and a different focus, but it's still a database randomized trial in the way that we're thinking about it. And this one I think is particularly interesting because of some of the secondary kind of data analyses that we did to really understand how the intervention might have worked. And so again, I have no conflicts to disclose. And so just still quickly level set, we care about adherence to medications because it's common and we know it leads to costly and preventable clinical outcomes. And one way we're interested in trying to address adherence, not just us, but many others, is that there's a lot of interest in text messaging interventions to support adherence. For several reasons, right? 1, they're cheap to administer. 2, patients have their smartphones on them all the time. I'm guilty as well. And that this is something that isn't just a problem that is something that even among racial and ethnic minorities, they have many access to smartphones as well. And so the problem is a lot of the interventions that have been studied so far have used relatively generic content in the way that we have provided information in terms of text, really a one-size-fits-all approach, even though from other contexts, we know that people respond differently when thinking about risk communication to the way in which information is framed for them. But trying to figure out how to tailor or personalize at scale, especially over time, is something in the medication world we had not seen done very much. So that was really the motivation behind this. And so we sought to use a machine learning strategy called reinforcement learning without getting too deeply into it. The idea is that it is a way that uses a systematic trial and error feedback loop, where essentially it observes an action, sends out some sort of cue, and then actually evaluates the response in response to that cue. So thinking about text messaging, we could observe how someone takes medication. We could send them a text message. We could see how they respond to that text message in terms of how they take their medication. And this is something that has been widely used in computer gaming, but not as much in the world of medications. And so this is a much smaller pragmatic trial that we did, and also done in Massachusetts. We identified everyone through the electronic health record. And because of COVID, we actually did this completely virtually. And so our patient population was a relatively standard patient population that had diabetes, who who were using oral medications because of the way in which we were measuring adherence in this context. They had to have a smartphone, they had to have some evidence of poor diabetes control, and for this intervention, they had to be willing to use electronic pill bottles, which for those of you who know about adherence, maybe you're familiar with them, but essentially they're retail-like pill bottles that have a cap on them that track the dates and times of pill bottle openings. And they're used in a variety of different contexts. And so our intervention itself involved giving patients these electronic pill bottles where it tracked how they were taking their medication on a daily basis, both dates and times. It uploaded to a web platform. Our reinforcement algorithm that we used was actually offered for free by Microsoft Personalizer. But in essence, you could think about any type of reinforcement learning algorithm for this. It read in the daily data about how patients were taking their medications, predicted the text message that patients would get. And this is really what the intervention looked like. The control group got the electronic pill bottles, but really no other intervention. And so how did the algorithm know to classify the text messages? Well, we actually told it what types of behavioral factors should go into the text messages. Different things like how the message was framed, whether it was positively or negatively, whether there was observed feedback about how they took their medications in the last 7 days, whether it invoked some sort of social cue relating to loved ones, etc. So we ended up with 128 text messages that were all coded differently, and that's how the algorithm actually picked the text message. And so the outcome we measured ourselves was medication adherence, which we measured from the electronic pill bottle data. And it was the proportion of days that medications were taken in the 6 months after randomization. And after we did the study, we also used different k-means clustering techniques to try to understand what types of patients responded differently to different types of text messages. So our patient population, there were some slight imbalances actually in the nature of having a 60 patient sample. And so we sought to really kind of account for those and adjust for those in our models. And so before we get into the results, a couple of things we found interesting. So part of it was understanding, does reinforcement learning why did we go to the trouble of this if generic text messages could work? Well, we found that over time, the reinforcement learning algorithm did evolve and actually improve in its predictions in terms of our squares. We also found that kind of immediately, on average, across the population, it really did not like negative framing as a way of motivating patients almost immediately off the bat. That was kind of the most noticeable thing on average. And what we found, it's a relatively busy slide because we think some of the subgroups were interesting to present, but on average, the intervention was associated with a 14% increase in adherence relative to the control group. And what was really fascinating to us, and especially notable looking at subgroups, is that there was a huge divergence in how poorly controlled patients were at baseline. Clinically, it makes sense. Those who were much more uncontrolled really didn't derive a benefit from a simple text messaging intervention. But those whose A1Cs were kind of in the margins, nearing control, those are the ones that had the greatest benefit. And so when we did other types of data analyses to sort of, now we know the intervention, we think it works, we think it evolved. But what does that mean in terms of lessons for other individuals and how people respond to text messages? Well, we found that across these different categories and demographics, that there were some differences in terms of characteristics of people who responded differently to different types of text messages. Kind of one of the biggest differences we noted was sex in terms of male versus female and sort of who responded. And so women actually preferred getting more information about how often they were taking their medications than men, for example. But we're less likely, oddly enough, to respond to social or loved one type messages. This is a small sample, kind of exploratory, but really something we started to think about and how we might think about moving forward with this type of work. And also when we did our k-means clustering, we found there were kind of 3 different groups who tracked differently in terms of the types of messages that they responded to. So there was a relatively unique group of individuals who really responded the best to just knowing how they were taking their medications, how many days they took in the last 7 days. There was a relatively small but distinct group of individuals who responded best to social cues as well as how they were taking the medication. Then there was a group in blue that was relatively agnostic and I think responded to everything. So this was a pilot study. And what we were really motivated by was thinking about how we could use this type of machine learning technique to improve potentially the way in which we deliver interventions at scale. And we found that it improved adherence over a 6-month follow-up. And thinking about scaling this moving forward, it was the bubble patients in terms of their glycemic control that really saw the greatest benefit. And so this may be something others might be interested in when thinking about other interventions in this space. So I just want to say thank you, of course, to the team at the Brigham and others who have been involved in this work. And thank you in advance for any questions you have.
Go ahead, introduce yourself, please.
Thanks. Hi, Sophie Botts from Utrecht. Very nice idea. I really liked how you did this. I have 2 questions. One is maybe a very short one. I understand why you used the electronic pill bottles. Did you have to tell patients that ethically or not? Because I can imagine if some patients, if they know, they just twist it and then close it again. But was wondering how you why you decided on telling them.
Yeah, I mean, we have to get informed consent when we give patients these types of pill bottles. They are used in a variety of contexts, like industry uses them for really expensive medications, but we haven't gotten to the point where we're just going to give people electronic monitoring without them knowing. It's just not something that we've done yet. So what we tried to do to wash out that was give it in both groups. And you have a valid, thought about patients just kind of playing with it. Other groups, not necessarily us, have done a fair amount of work kind of looking at this Hawthorne effect. Like, how does it change how people use medications? And it lasts for maybe 2 weeks to a month, the novelty of the medication pill bottles. And after a while, patients are just going to take medications in the way that they would ordinarily. And so we were less concerned about that by doing, say, a 6-month follow-up than we would if we were doing it over the course of a month.
Thanks. And another question is, you showed the subgroup analyses with the HbA1c, but given the very small sample that you have, I would be cautious in moving forward, only looking at the people with the controlled HbA1c, just because, challenge could happen there. So yeah, that was just more an observation. I don't know how because you said moving forward, you might focus more, but.
It's a great question. We're actually testing this now in a community health center context. And we thought for a while about whether we wanted to double down on moderately poor glycemic control rather than everyone. And we decided to keep all comers for that reason.
Hey, Helga Karlsdottir, also from Utrecht University. Thank you for this really nice presentation. I was curious a bit about the follow-up because, of course, there's a lot of interventions that we're measuring how to improve adherence. And I was wondering, are you going to look a bit further than the 6 months? Did you see any kind of ebb off in month 5, 6? Because often we get very positive results and then kind of the interest and the novelty of this intervention kind of ebbs.
Yeah, we have plotted out kind of what the curves looked like and it stayed relatively separate. It's a good question. This was actually honestly my first foray into electronic pill bottles. I prefer measuring adherence over claims for all the reasons you all are mentioning. But we were sort of stuck in a world where we needed daily feedback. And so we kind of decided that 6 months would work for now. We're hoping to test this at larger scale and look at a year. And sort of see how it goes. And the other motivation for thinking about identifying groups of people who respond differently was that maybe at some point we could not have to use electronic pill bottles and we could already tailor the intervention a little bit better.
Do we have a couple more minutes? So can we go back to that question about the previous presentation, maybe?
Thank you. Thank you very much. My name is Henry from McGill University. I was curious, you said earlier that you applied some behavioral principles. So I was wondering if you explored any reward-based principle, and if you didn't, what are the likely reward principles that we could use, knowing that reward works really well, especially with nudging people people to change behavior? Thank you.
Yeah, it's a great question. So the deprescribing one. We didn't choose rewards. We were trying to rewards, I think, have two meanings sometimes, depending on the context, whether it's financial rewards or non-financial. We definitely didn't want to go down a road of financial rewards for what we were studying with the EHR-based tools, even though we know that even with providers that could potentially be effective. I think it was really just a function of, we didn't want to assume that many providers would have patients kind of accumulating over time, and sort of, we wanted to try to treat the patients as independently as possible in the way that providers would be treating them. But it's a good question and something we could consider for the future. What's that? Yeah, it's a good thing to think about. Yeah. I think we're probably at time, but I would love to chat with you after if you'd like. Okay. Thank you.
So, yeah, okay. So let me go first to that. All right, so where is Jenny? Okay, so our last presenter for this afternoon is Jenny Lee, and she will be talking about treatment effectiveness of oral disease modifying agent in multiple sclerosis, adjusting for adherence trajectories. Please come.
So good afternoon, everyone. My name is Jenny Lee. I'm a PhD candidate from the University of Houston Department of Pharmaceutical Health Outcome and Policy. Today, it's my pleasure to present our project in evaluating the treatment effectiveness of oral disease modifying agents when considering patients' adherence trajectory for multiple sclerosis. So this study was funded by an HRQR3 grant under the principal investigator, Dr. Raja Prasu. For those of you who are not familiar with MS, multiple sclerosis is a chronic progressive autoimmune disease that impacts about 1 million individuals in the United States. MS mostly affects the reproductive age of women. And in addition to cognitive impairments and significant neurological symptoms, our group's previous research also identified that patients with MS was associated with a diminished health-related quality of life and also a significant healthcare expenditure burden. The prescription costs will actually account for over 60% of the overall healthcare expenditure among multiple sclerosis patients. Although there's no cure for MS, the introduction of disease-modifying agents, which aim to support the immune-mediated systems, also helps the patient to reduce their risk of relapse and also to delay the progression of disability. The disease-modifying agents were firstly introduced as injectable and infusion form. In 2010, the first ever oral disease-modifying agent, the fingolimod, was introduced and approved into the US market. At this moment, there are about 9 oral disease-modifying agents were approved, which provides an convenient treatment option for multiple sclerosis patients. Within the oral disease-modifying agents, fingolimod was found to be one of the oral types associated with a better response rate in reducing annualized relapse rates. However, the treatment adherence were never being considered or adjusted in other previous published observational study when evaluating the comparative effectiveness of oral disease-modifying agents. As we all know, adherence is really important and will lead to a tons of positive treatment outcomes for patients. On the other hand, the poor adherence will lead to more relapse, a faster disease progression, and moreover, it will also lead to more healthcare utilization and healthcare cost. Therefore, in these studies, we aim to evaluate the oral disease modifying agents and their adherence trajectories in reducing the annualized relapse rates among patients with multiple sclerosis. The study is a retrospective observational study that considered 2015 to 2019 IBR market scan commercial claims data. Based on the study period that we have selected, so we only consider 3 types of the oral disease modifying agents, which including the fingolimod, teriflunomide, and dimethyl fumarate. We selected adult MS patients who had at least 1 oral disease modifying agent prescription record, and we assigned their earliest date of the oral disease modifying agent prescription date as their index date. Next, we group the patients by their 12 monthly adherence trajectories indicators, and then we evaluated their annualized relapse rates during the 12 months following the assessment period. Although the relapse is not an available variable within the commercial claims data, we considered a claims-based algorithm to actually evaluate and examine patients' annualized relapse rates. We also applied the continuous enrollment criteria to ensure that we capture the comprehensive healthcare utilization from the patients. In the study, we select our variables based on the Anderson behavior model. So we including typical predisposing and enabling factor, such as patient's age and their type of health insurance. For the need factors, in addition to the comorbidities, prevalent comorbidities among MS populations, we also consider a list of MS-related clinical relevant variables, such as some MS-related symptoms and MS-related symptomatic medication. Different from previous studies that use a point estimator, for example, if the patient have MPR greater than 0.8 or not. In these studies, we evaluate the longitudinal changes of the patients and also to model the patterns of medication adherence by using the group-based trajectory modeling. So in the studies, we built the model based on patients' 12 monthly PDC, the proportion of this covered for the patients to evaluate their adherence trajectory groups. In order to limit the selection bias, we applied the gradient generalized boosted models based IPTW to balance the two cohorts, the several cohorts in the studies. The generalized boosted model is a machine learning technique that can provide the optimal stable weights to balance the cohort in the study. And also, we consider the generalized linear models with the Poisson regressions to evaluate the reducing in relapse in the study. Moving forward, I would like to share the results. So first of all, we start about 80,000 patients, and after we applied the inclusion and exclusion criteria, we ended up about 500 dimethyl fumarate patients, 200 fingolimod patients, and 200 teriflunomide patients. We select the best group-based trajectory model based on the BIC as well as the subject interpretabilities. Accordingly, patients were grouped into 3 groups. So about 50% of patients, which are in the green lines, are completed adherent, so they stay with the treatment well. And about 25% of patients are slow decliners, which are shown in red. And the rest of the 70% or the rapid decliners, which was shown in the blue line. Our multivariable models also found that the fingolimod users shows an equal response as the dimethyl fumarate patients, but a better response than the dimethyl fumarate patients in reducing the relapse rates. And moreover, we also found that the rapid decliners and the slow decliners are both perform less when compared to the complete adherence when we evaluating the outcomes of reducing the relapse. We also checked the interaction term and we found there's no moderation effect in the interaction terms, so we do not ignore that when we compute the multivariable models. Our study findings were slightly different from the results in other previous published observational studies when evaluating the comparative effectiveness in reducing the annualized relapse rates. But as I mentioned, the previous observational study didn't consider the treatment adherence when they evaluating the outcomes. On the other hand, like patients from other chronic conditions, the poor disease-modifying agents adherence can worsen the disease and can also make the management of disease more challenging. The study expands our understanding regarding the comparative effectiveness in a real-world setting. And also, this study provides a really important implication. Although the oral disease-modifying agents is a really effective and convenient route of administration for the patient to use, but it's been shown that the oral disease-modifying agents are more likely to benefit for those patients who stay with their treatment well. The studies is considered really highly generalizable populations when evaluate outcomes and provide important real-world evidence for MS care. However, when we interpret results, there are some of the limitations that we need to consider. So first of all, several factors such as patients' MRI lessons and patients' EDSS, which is their disability scores, were not available within the claims data. But we considered a claim-based algorithm to examine the as a proxy to examine patients' severity level, which we have been considered and included in our modeling process. And also, there are other oral disease-modifying agents were approved in recent year, which we are not able to consider in the study. So future studies should evaluate all of the oral disease-modifying agents available in the market in order to provide a comprehensive evaluation. So overall, the studies identified that longitudinal medication adherence patterns are really important in reducing relapse for a patient with multiple sclerosis. And the differential intervention should be considered and needed to help patients and providers to achieve the optimal treatment goals and also to improve the quality of care for multiple sclerosis patients. Lastly, I want to give special thanks to my collaborator, Dr. Erla, Dr. Hart, and Dr. Apraso for their support. I think now I'm able to take any questions or comments.
Hi, thank you for your talk. I am not at all familiar with the MS field, but I was wondering, you were comparing two treatments. Is there any difference in the indication for those two treatments between patient groups that could explain why you find this difference in adherence pattern?
So all of the three oral disease modifying agents that we considered are all of them are indicated for as the first line treatment for the disease modifying for the multiple sclerosis patients. And also we kind of apply the IPTW to balance any potential selection bias for different groups.
Okay, and you also, I'm not sure if you said it, but you also included people at their first prescription.
Yes, so all of the cohort is a new user cohort. So we are kind of looking to their first ever disease modifying agents use.
Thank you.
Thank you.
Hi again, my name is Henry. Thank you so much for your presentation. I just have two follow-up questions. I know it's not part of your outcome, but I was wondering if you actually looked at the predictors of being included in a trajectory group. Like what's actually predicted being a part of a trajectory group? And the follow-up question is, were the groups, did they appear clean, or did you have to merge groups to make some sense?
Yes, so for the first questions, this is actually kind of like an aim-2 study. For our aim-1 studies, we do look into for the different trajectory groups, is there any factors? And then the answer is yes, there are different, like for example, like age, I don't think gender, like age, and then there are like baseline comorbidities conditions are the kind of like the factors gonna impact the adherence trajectory groups. For the second question, so yes, there's like no detailed rules to select the best models to perform the group-based trajectory model. So there's like two scenario like rationale that we need to follow. The first one is look to the model performance. So we look into one of like the low BIC models. And then the second one is also to look into the subject interpretability of the model. Is it like looks like reasonable to interpret? Thank you for your question.
So I think it's break time. So thank you very much to all of our speakers. And thank you for staying and for making these interesting questions. So over to coffee, tea, whatever. Thank you.